Afternoon, everyone. I'll be presenting on lung function test. So let's see what we'll be learning today. Spirometry, the obstructive, the restrictive patterns, interpretation of the spirometry, body plethysmography, lung volume and capacity, interpretation of the lung function, and then we will have some fun with these numbers. So what is spirometry? Spirometry basically assesses lung function by measuring the airflow that the patient is able to expel from the lungs after a maximal inspiration. So there must be a, and then you go on. So values expressed as a percentage of the predicted normal for the same age, ethnicity, gender, and height. If there is scoliosis, we can use the arm span. So the indications for spirometry will be to differentiate between obstructive, restrictive, and mixed pattern, the site and the type of obstruction, whether it's intrathoracic or extrathoracic, the impact of therapies, the degree of impairment, pre-op assessment of the child with chronic lung disease or neuromuscular weakness, and also to monitor disease progression and prognosis. Contraindication would be hemoptysis of unknown origin, pneumothorax, unstable cardiovascular status with recent myocardial infection or pulmonary embolism, thoracic, abdominal, or cerebral aneurysm, recent eye surgery, thoracic or abdominal surgery, or any acute disorders affecting the test performance, such as nausea or vomiting. So you don't do it during those times because the results might not be interpretable. So these are the normal values of the pulmonary function test. So FEV, FVC about 80 to 120. FEV1, FVC ratio within 5% of the predicted ratio. Reversibility is usually 12%. Total lung capacity is about 80 to 120. Functional residual capacity and residual volume is about 75 to 120. And this thing called maximal mid-expiratory flow will be less than 65, will be considered impaired. So this is how a spirometry would look like. This is where you will be, this is the mouthpiece, and this is where the readings come up. So a good results would be something like this, where there'll be 3 trials, and they're all not further apart from each other. If you can see this graph, there's 2 graphs that will be generated. One will be volume against time, the other one will be flow against volume. So there are actually three different shades of green here that you can see, and they are all overlapping very nicely. So this shows that they are actually reproducible results. So yeah, so 3 efforts with evidence of an explosive start. So they must all have like a very good inspiration before you proceed. So they will all come up with the same kind of a curve. So let's see an obstructive spirometry pattern would look like. So FEV1 to FVC ratio will be less than 80%. The reduced FEV1 will be more profound compared to the FVC. So that's why when you measure the ratio of these 2 values, you will get less than 80%, which is different from the restrictive. So in obstructive pattern, there is usually, so this is how a normal curve would look, volume against time curve would look like. So in an obstruction patient, in the patient with obstructive disease, there will be the FEV1 would be impact more compared to the FVC. The FVC is still preserved at the initial stages. So you can see that it is the FEV1 here that is impaired, but it still reaches the same FVC. Okay, but of course not all, because eventually in severe obstruction, the FVC will be reduced as well. So this is when you start to have a mixed pattern. In terms of the flow to volume kind of graph, you can see that there is a concave appearance at the descending portion of the expiratory limb, like this. So this is the coving that you can see. So this shows that the air that is trapped inside is taking a bit of time to flow out. Example of conditions would be asthma, cystic fibrosis, bronchiectasis, and post-infectious bronchiolitis obliterans. So we have this forced expiratory flow, which is 25 to 75%, which is at this area. So I'll be showing here. So you can see that this is the forced expiratory flow. So this is actually a very sensitive parameter for assessing peripheral airway function, which is the small airway diseases. So we are taking it from here to here. So that is why in your lung function test, it is called maximal mid-expiratory flow. So it's the middle of this expiratory flow. So let's take a look at this lung function. Can everyone see the numbers? Yeah. So we can see FVC is about 36. FEV1 is about 20. So the ratio is about Who says the ratio is 48 and who says the ratio is 55? So the ratio is going to be the ratio is going to be 48. It's not going to be this number because this number is a percentage of it's a percentage of the percentage. Get it? So this value is not, yeah, so this value is not correct. So you are going to see this one where it is a ratio between the actual values and not a ratio between the percentages. So in this case, you can see that FEV, the ratio is 48, which is less than 0.8. So it's an obstructive picture. And then you see that FEV and FVC is also reduced. So it is something, this is a bit typical with the total lung capacity is also low, 66. So it's classic in post-infectious bronchiolitis obliterans. And we can take a look at this MMEF. You can see that it's only 5%. So less than 65 is considered impaired. So this is classic in post-infectious bronchiolitis obliterans. So to assess reversibility, first we do a spirometry, make sure that the patient has already not taken salbutamol or steroid for more than 12 hours. You can administer 400 mics of you take 4 puffs of salbutamol and repeat the spirometry 15 minutes later. So how we calculate is we will see the FEV1 pre. We will choose the highest, which is 1.21 among all these readings. And then the poles, we will also choose the highest, which is 1.38. And then we measure with in accordance to the baseline, which is 1.21. So in this patient, it is 14%. So reversibility is positive.
So your money, these are
So we move to restrictive spirometry pattern. So in restrictive spirometry pattern, the FEV1 and FVC ratio will be more than 80%. Why this happens? Because both FEV1 and FVC reduces in equal proportion. So when they are compared to each other, they still produce a result more than 80%. So in this pattern, you can see that the volume is affected rather than the flow. Okay, volume. So obstructive is more of a flow problem. Restrictive is more of a volume problem in general. Examples would be interstitial lung diseases, pulmonary fibrosis, chest wall deformities such as kyphoscoliosis, and neuromuscular disease. So we see this type of in testing. So this is an example of a restrictive lung disease, or is it? So FEV, FVC, the ratio is 92, so it's more than 80%. FEV and FVC is 47, 47. So it's also low, right? So you think that this is already a restrictive kind of a lung disease. However, there is actually missing lung volumes here. So you see that total lung capacity is not measured here. So at best we can say query restrictive lung disease. So this brings me.
So meaning, please, if you suspect anybody with lung, don't claim to do lung volumes.
So this brings me to my next topic, which is lung volume and body plethysmography. So you can see that this is a body box, or they call it plethysmography. It is a sealed container. So inside this box, the pressure and the volume is already fixed. So now they are going to measure the patients. So there is this. So this is the mouthpiece. Patient will be breathing into this mouthpiece. So by breathing, he's actually able to measure the tidal volume as well as the force vital, the force expiratory. He can basically you can have your spirometry readings, but you do not have this residual volume. So the only one that we are missing from the spirometry is this residual volume, because the residual volume, there's no way we can measure it with spirometry. So go back to this body box. This patient is going to breathe into it, and then there will be intermittent obstruction, occlusion from the machine, which will be able to measure the pressures that the patient is able to generate. So when we use Boyle's law, we have this pressure of the pressure and the volume of one system is going to be equal to the pressure and the volume of the second system. So in this case, we have the patient and the box. So when we can measure the pressure that the patient is exerting, we can actually measure the volume also. So that's how we get the residual volume. So these are all just definitions, which we can all go home and read about it.
You all are supposed to know. In fact, that's the important. This is actually This is the important thing that you all also have learned before, so you must know. But I think in time, I'm sure enough.
Okay. So yeah, let's look at this lung function test. So now we can safely conclude that this is a restrictive lung disease, unlike the one that we saw previously. Yeah, because there is total lung capacity. There's a total lung capacity in this lung function, which is 72. It's less than 80% is considered abnormal. So again, 92, low, high, low. Okay. And you can see that the MEF is 86%. So it's normal. So it's not an obstructive problem. It is a restrictive. It is a purely restrictive lung disease compared to the ones that I'll show you later on. So interpreting lung function tests. So again, the age, the race, gender, height will be used to calculate the predicted normal values for that individual. And also need to know when was the last salbutamol and serotype used, as they're going to interfere with your results. So to assess the quality of the results, you need 3 consistent volume time curves are required, of which the best 2 curves should be within 5% or 150 mils of each other. And the best of the 3 readings will be taken for your interpretation. Make sure that it is free from abnormalities such as coughing during expiration, extra breath. So during the expiration, so that means while the patient is blowing, he takes a bit of breath and then he continues to blow. So it's going to add on more volume. If there's any slow start to force expiration, so your FEV1 is not going to look very good, and or any sub-maximal effort. That's why you need 3 readings that is going to repeat itself. So first we will be looking at the ratio of the FEV and FVC. If it is normal, you will think of restrictive. If it is abnormal, you will think of obstructive. But you still need your total lung capacity here. So once you see FEV1 and FVC ratio, then you look at the FVC number in general. If it is normal, then we will say it's normal. Generally, we do not do DLCO. So for lung function only, we'll often come up with this conclusion, whether it's normal, restrictive, obstructive, or a mixed effect. DLCO is not routinely done. Of course, sometimes it's done because the price is the same anyway when you order the lung function. Yeah. So 60 ringgit anyway. So it often gets. So then after looking at the FVC, if it's normal, then it's normal. So if everything goes normal, then it's probably a normal patient. If let's say the vital capacity is not normal, then you still have to look at the total lung capacity. And if it's also low, then it is restrictive. If it is not, then it is obstructive. So even if let's say your FEV, FVC is more than 80%, it can still be an obstructive lesion. It can still be an obstructive disease. So it's important to make sure that you have a total lung capacity when you're interpreting. And then when it comes to mixed defects, you can see that the FEV1 FEC is suggesting more of obstructive. However, your vital capacity will be your total lung capacity will be low. So in obstructive, we know that the total lung capacity is supposed to be normal by right. But if it's low, then you think of a mixed defect. So it's obstructive with restrictive. These are just example of the diseases. So let's have some fun with some numbers. So
you just show them one lah. I think that's right.
Okay.
Who's your favorite one? Okay.
Okay, so we see this. So we start the interpretation of FEV1 to the ratio. So again, they are going to take 61. So 61 is less than 80%. So this one would suggest an obstructive disease. So again, FEV1 is 60 and FVC is 85. So we know in obstructive, FEV1 will be low and 85 is often and the FVC is often preserved. So this is and MEF is low, 34. So it's less than 65 is impaired. And the total lung capacity is normal, 87. So this is a classic obstructive lung disease. So this is not the number, okay? This is not the correct ratio. So this is another one more. So again, it's pretty similar to the one previously, but something here that we need to interpret further. So FEV, FVC is 86 normal. So FEV1 and FVC is low with FVC preserved.
73, yeah.
Yes, 73. And then total lung capacity is 106. Total lung capacity is 116.
Okay, so this is what?
So this is
So this is obstructive, restrictive, mixed.
so this is also a classic obstructive, but there's something else that we forgot to interpret. The reversibility here. So so here we see the FEV1 is 1.27, force is 1.31. So in this case, we also have to interpret that there is no reversibility, which is only 3%.
So remember, reversibility is FEV1. Don't look at NBC, don't look at the ratio.
Okay, so last two.
Still
So
got one more.
yeah, still got this is yeah.
Okay.
So the ratio 81. So this
Hey,
is
you're still pointing at reference.
oh, okay. Yeah. The ratio is 38.
The ratio is?
Ratio is the 38. And then the FEV and FPC is 33 and 15. So it's low. So it's low, low, low. So what would this suggest? A total lung capacity of also low. So everything is low.
So what is this? Scala.
If your FEV1,
Yes, it's mixed.
yes. So this is severe obstructive disease complicated with restrictive pattern. Yeah.
Right, so this chart is what? Look at FEV1 of 15%, right? So his primary problem is obstructive disease, but so severe that you end up having a restrictive disease, that vital capacity. So this is classic pattern for my post-infective bronchiolitis syndrome.
Yeah.
Hey, this one I think is mission. You know, this one mission.
Yes.
This mission also lah, or severe bronchitis lah. So this guy could be severe bronchitis, but my insurance now I PIPO. This could be my big neurons mission.
He's 22 years.
But
Yeah.
my
Sure.
PIPO also have a very similar pattern as well. Very severe obstruction in so severe that it affects your lung volume.
You can also see this FEF 25 to 75. You can see that it's only 5%, so it's severely impaired. So that's how it does. So another one.
This is mission lah.
This is they're both Nishan.
Oh, yeah.
Technically they're both.
Okay,
But
okay.
it's the
Hopefully
same.
you all understand because it's commonly we like to ask spirometry and lung volume.
Right. Thank you.
Okay, you want to present your case?